Hi and welcome back to another video of Medic Notes. This video is on gastroesophageal reflux disease. GORD is the most common upper GI diagnosis and most people have some degree of reflux, especially after meals. It can be caused by a few factors. Esophageal clearance. Efficient clearance normally relies on gravity, saliva flow, normal motility, and fixation for efficient peristalsis, which is lost in hiatus hernia. Second factor is lower esophageal sphincter competence. Resting loss pressure should be more than 5 mm of mercury over distance of more than 1 cm. Loss pressure reduced in smokers, women on OCP, people on atropine, and pregnant women. Third factor is gastric clearance. This relies on normal secretion, rapid clearance, and normal nerve supply. Thus, GU can lead to reflux. Clinical features of GORD: epigastric, retrosternal, or interscapular pain, angina-type pain, odonophagia, reflux of food, globus or lump in throat, where the cricopharyngeal bar may be seen on barium swallow, and pulmonary aspiration, also known as gastric asthma. For diagnosis, history may show effect of posture and antacids. Patients aged less than 55 with no worrying symptoms or risk factors require a urease breath test or a stool antigen test to rule out Helicobacter pylori. If positive, it should be eradicated. If negative, then a trial of proton pump inhibitor for 1 month should be given. Investigate further if there is history of weight loss, anemia, anorexia, family history, or Barrett's esophagus. All patients aged more than 55 with new symptoms of GORD should be investigated. Endoscopy is the first investigation of choice for reflux. It makes the diagnosis in 70% of cases and can confirm by biopsy. Can diagnose Barrett's esophagus. Can also show changes proximal to the squamocolumnar junction. Biopsy is diagnostic in 80%. Tissue from 5 cm above GOJ shows increased eosinophils and hypoplasia. pH monitoring is the gold standard for diagnosing reflux. Esophageal manometry. Barium swallow. Useful to diagnose hiatus hernia, but not definitive investigation for reflux. And rarely Bernstein acid perfusion test. Complications of GORD. Esophageal stricture, which is treated by balloon dilators or tapered bogies. Dilation is carried out under endoscopic or radiological control. Surgery involves an anti-reflux procedure, such as laparoscopic Nissen fundoplication. Esophageal replacement is rare, used in young people, recurrent stricture, undilatable stricture, or shortened esophagus. Barrett's esophagus. Defined as an acquired condition where any portion of the normal squamous lining is replaced by metaplastic columnar epithelium which is visible macroscopically. This should be confirmed histologically. It represents the extreme end of GORD and exhibits risk of malignant transformation. Bleeding. Rare in reflux disease unless there is severe erosive esophagitis. This is a picture showing Barrett's esophagus. For medical treatment, conservative actions such as lose weight, raise bedhead, decrease size of evening meal, and reduce alcohol intake. Antacids. Metoclopramide, which increases loss pressure and increases gastric emptying. H2 receptor blockers like cimetidine and ranitidine. Proton pump inhibitor like esomeprazole and lansoprazole. Surgical treatment. Most anti-reflux surgery involves some form of stomach wrap around the lower esophagus. This limits reflux by decreasing hiatus hernia and increasing loss tone. Surgeries include Nissen 360-degree fundoplication, TUP, DOR, Belzy Mark IV, Hill repair, Angelchik prosthesis, and Roux-en-Y procedure. That's all for this video. Thank you.